Yeah.
and
Yes.
have your presentation now. Thank you.
Yes. It's you can see my screen, my PPT.
Yes,
Perfect.
yes. Thank you.
Yeah. Once again, welcome to this symposium. My topic is the invention and innovation of video supraglottic airway devices. I'm Dr. Minjiang Zhou from Beijing Hospital. So this is our outline. As we anesthesiologists know, the safe airway management is the top priority of anesthesiologists. We should use various airway management tools to deal with difficult airway. And we should know and familiar with the difficult airway guidelines. And we try our best to maintain airway patency and maintain adequate ventilation, oxygenation, and gas exchange, and to avoid regurgitation and aspiration. As we know, in 1846, Martin successfully demonstrated the ACE anesthesia in MGH. It marks the beginning of the modern anesthesiology. Since 1846, anesthesiology gave the patient no pain, no movement, but followed by anesthesia-related mortality and morbidity. We can see in 1850, the mortality is 1 in 100, but now even in China, it's in 1 in 200,000. It's decreased a lot. Why? Because we can see in 1991, since 1990, we have a saturation monitor and an entitled CO2 monitor. In China, it's about 2,000 years, we started to use the saturation and the entitled CO2 monitor. I think this makes the anesthesia safer. Of course, there are a lot of the difficult airway management algorithm. Since so far to 2 years ago, there is a 38 published airway management algorithm. We're all familiar of this algorithm, and the different countries have different difficult airway management algorithm. This is a China difficult airway algorithm from the Chinese Society of Anesthesiology, 2017. We're thinking about why anesthesia become much safer. I think there are some reasons. One is we have a very good anesthetic drugs, and we have anesthesia monitoring technology advancement. And there is an advance in anesthesia teaching, standardizing training, and scientific research. And we do a lot of the training program for anesthesia related to the guideline. And the last one is development and advancement of IV management tools. This is a question: is safe IV management is a top priority of anesthesiology, as we all know. But in my opinion, it's always on the way. This is one case in China. Is do the urological surgery, a small surgery. They tried to intubate the patient 7 times, but finally failed, and the patient caused the brain damage and pay about 1 million Chinese yuan. How about the United States? This is a management of difficult IV trach intubation across claims analysis. You can see compared to the 1993 to 1999, 2000 to 2012, you can see the claims the decline in quantity, but the ASA more severe, more sick patient, and the claims increase the incidence outside the operation room, and the mortality increased in recent 2000 to 2012. And there are some problems in 2000 to 2012 claims preoperative predictors of difficult trachea intubation were presented, but in 76%. But anesthesia doctor may not pay more attention. And in the 97 claims with sufficient information of assessment, inappropriate IV management occurred in 73. And one CICO emergency occurred in 80 claims with delayed surgical airway in more than 1/3. So, I mean, that is a safe IV management is always on the way. There is some pulmonary aspiration of gastric contents across claims analysis. We can see a lot of regions, such as it's included, for example, nasogastric tube not placed before aspiration event, and the poor management of aspiration event, and use the supraglottic IV or mask in patient at the risk of aspiration, and the lack of the cricotide pressure when they do the rapid cycle induction, and the difficult intubation, premature extubation that causes the gastric contents aspiration. So I am quite agree with the editor review. Current difficult IV management not good enough. We should invent more difficult IV tools, and do more training programs, and make the difficult IV tools available in different situations. So the second one, I'm talking about the difficult IV development IV management. We know the MGH, the ASA demonstration, and we know how to maintain the IV chin lift, and the ETT nasal IV, oral IV, and ETT tube with cough, and laryngoscope. And in recent 30 years, the video laryngoscope is developed a lot. In China, about 90% of our general anesthesia, we use laryngoscope to intubate the patient. So that decreases the difficult intubation a lot. Why? Because the front angle of the blade becomes larger, and the building the camera that make us easy to see vocal cord and easy to intubate. There is another wireless disposable tip flexible rigid visual intubating state. I think it's quite good. You can see without the laryngoscope, it's easy to intubate. In my opinion, in future, video laryngoscope and intubate state, visual intubate state should be popular in our clinical practice. And now we have another visual ATT with a block. This is our patient. In my hospital, about more than 90% of our one-lung ventilation, we only use the visual ETT with a block. but some cases we have to use double lumen tube. So this is a development of the IV management tools. The third one is we're talking about the invention and the development of laryngeal mouse IV. We all remember Dr. Archibald. I remember 10 years ago in Singapore, we meet Dr. Archibald, and in China we meet Dr. Archibald a lot of times. He invented the laryngeal mouse airway. We all know the history of this story. In 1988, when Brain introduced the laryngeal mouse IV thick alamy, there were only two choices of IV management: tracheal tube and or face mask. There is the advantages of the laryngeal mask IV. This is why we use a lot in our clinical practice. RMA is more invasive than use of face mask for anesthesia, but less invasive than tracheal intubation. Hemodynamics were stable during insertion and removal. Easy insertion without laryngoscope reduce the demand of the anesthetic drugs during induction and recovery, and less so sought. This is a classification of supraglottic IV devices. This is the first generation SAD. They have only IV tube and mask. The cell pressure is about 20 centimeter water. This is, I just mentioned 20 more years ago. I worked trained in SGH and used a lot of classic RMA. And this is the second generation of SAD. They have an IV tube and a mask, and they have a drain tube. But they have a back cough. So the cell pressure is increased to 25 to 30 centimeter water. So at that time, we use a lot of this RMA in our general anesthesia. In 10 years ago, is about 30 to 40% of our general anesthesia. We use the laryngeal mask IV in our clinical practice. And there is some SAD, such as fast intubation RMA and the laryngeal tube, but it's designed for tracheal intubation. There is also the video SAD for, but they designed for tracheal intubation, such as RMA C-track. But now we cannot find it because they did not make it. And they are the total track. They're all designed for tracheal intubation. So how is it? We know the classical RMA and Perseo, Supreme, Ideal, and what is the future of what is the next generation of the RMA? So the first one is I define it as the third generation of SAD. That means the video SAD. They have a lot of features of second SAD as a video camera. That means they have a IV tube, large size of IV tube. That means we can intubate through the IV tube. And they have a drain tube. We can insert the gastric tube. And they have a large channel or the video channel. You can see through this mask to see inside the epiglottic inlet. This is invented in 2016, about 8 years ago. This is our first paper to demonstrate the cycle video laryngeal muscle IV. We use this cycle video VRMA about 100 patients. Our primary outcome was geologic visualization grades. The second outcome include cell pressure, success rate of insertion, intraoperative finding, gastric reflux, control position or male position, gastric drainage, and 24-hour completion of after operation. You can see 100 patients. The type of operation is gynecology surgery and general surgery, urinary surgery, and about 22-hour patient is pneumoperitoneal. Some is the laparoscopic surgery. We can see this is the primary outcome, geologic exposure classification. We do the grade 1, grade 2, grade 3, grade 4. After adjustment of cycle VRM, a lot of more than 100 of our patients, we can see the geologic inlet. Some see the vehicle code. So it's easy to see. And the successful rate is about 95%. Total success, first successful rate is 95%. The total success rate is 96. And you can see some we adjust the position once or twice, and the cell pressure is very higher, is about 34. Average cell pressure is 34 centimeter water. So the conclusion is cycle VRM can visualize the partial or whole larynge inlets during the surgery with a higher success rate and a higher sealing pressure and a smooth gastroesophageal drainage. So cycle VRM could be promoting new effective SAD for IV management during general anesthesia. So this is our how to insertion the VRMA and give the cuff pressure and give the cell pressure is 60 centimeter water to make sure the position is correct, and test the drain tube and the insertion gastric tube and fix the VRM. You can see the whole procedure. You can see this one. So after the surgery, we remove the tube, the laryngeal muscle IV. And the last the next this one is we use for the general anesthesia as a IV airway. This one is we can intubate intubating through the cycle VRM.
一，直接辅助插管，准备铜钱，另需润滑导管。
Lubricate the ETT. As a preparation, same as mentioned previously. Lubricate endotracheal tube.
插入可视喉罩，
and
在可视下
insert
插入喉罩，
video larynge
确
mask.
认对位准确后， 在持续供氧及可视下
And
进
you
行气道
can
插管，
intubate
调好
the
位置，
patient
靠
through
拢
the
吹气。
VRMA. At the same time, you can ventilate the patient without fiber optic scope. This is for VRM remover.
二，整体拔除，将气管导管及喉罩气囊放气后，将喉罩连同气管导管、胃管一同拔除。拔除后，确认病人意识清醒。二，整体拔除。
This is what we do in our clinical practice. And there is some articles published in Journal Clinical Anesthesiology in China. They use the 60 patient with sacral video laryngeal mask for the laparoscopic surgery. They get a very higher cell pressure and successfully used. So they gave a conclusion is a sacral video larynge mask has a higher IV saline pressure and a correct position that Supreme does, and can be safely and effectively applied for the IV management in laparoscopic surgery. He compared with the Supreme Alamy. You can see they have a Supreme and the so-called RMA video larynge mask. You can see the very high successful rate, and the cell pressure is. You can see the very insertion is very fast, and cell pressure and the position and the gastric insertion, and you can see the complication is less. And this article is use the video laryngeal mask IV and through the laryngeal mask IV you use the bronchi block compared to the ETT with bronchi block used in the elective minimal invasive thoracic surgery. The conclusion is the combination of sacral laryngeal mask and the bronchi block in minimal invasive thoracoscopic surgery can achieve good intraoperative ventilation effect and get better quality of recovery. You can see this is RMA and ETT that use the left or right side bronchi block. They achieve a very they use very successfully use this one. And this is for the hip replacement. They use the sacral RMA, just like the Lomo SAD. And for the aneurysm surgery, and for the pediatric patient for the orthopedic surgery. And this article is quite interesting because they reported the insertion of the sacral VRM in 3 awake morbidity obese patient. The BMI is 46, and the patient will give intravenous atropine and the midazolam injection after patient in the operation theater, and then give the lidocaine for the topical anesthesia. Then they insert this sacral VRMA when the patient awake and keep the breath spontaneously, then they can see the vocal cord. And they give induction and intubate the patient through the VRMA. The conclusion is that cycle VRMA is easy to use, well tolerated, and suitable for the awake oral trachea intubation in patients with obese patient. And quite interesting for this kind of patient to give the night sedation and give topic anesthesia, insert the so-called RMA, VRM, then they intubate the patient, then induction. So the advantages of video laryngeal muscle IV is there is some we can continuously monitor the position of the laryngeal muscle airway, and the timely observation and the cleaning of reflux secretions blood, and finding the cause of laryngeal muscle IV leakage, such as light anesthesia and the laryngeal muscle movement. And we can intubate the patient through the laryngeal muscle, video laryngeal muscle IV without fiber optic bronchoscope. And we can ventilate the patient during intubation to avoid hypoxemia during intubation. So in my opinion, the next generation of the laryngeal muscle IV in future is what I mean is a third generation of SAD. That means video SAD equal to second SAD with a video camera. The second SAD should have a large IV tube that's easy to intubate and have a drain tube. So this is my opinion. Finally, I give the summary. Safe IV management is a top priority of anesthesiologists. Advancing IV management tools will reduce anesthesia-related morbidity and mortality. IV management, laryngeal muscle IV plays an important role both in routine IV management and difficult IV management. In future, video supraglottic IV devices will play more important role both in routine IV management and difficult IV management. Thank you for your attention. Thank you.
Okay, thanks, Professor Zhou. That's a really informative and excellent presentation, whatever from the history of the supraglottic airway devices and its clinical usage. So we learned a lot. Thank you very much. Thank you, Professor Zhou.